Should I leave the waiting room enabled, Michelle, or disable it?
Oh, you can disable it after that. Yeah.
Okay.
Okay. I started recording.
Okay. Should I start? Welcome, everybody.
Welcome.
Welcome. So thank you everyone for joining today's CUNY School of Public Health Grand Rounds. Today's talk is sponsored by the Center for Innovation Mental Health, which is a research center at CUNY SPH that's focused on using community partnered implementation science approaches to increase access and quality of mental health services for diverse communities. I'm the director of the center, and today I am especially excited and honored to introduce my dear friend and colleague, Dr. Theresa Bettencourt, to the CUNY School of Public Health community. Dr. Betancourt is a leading global mental health implementation scientist who's dedicated her research career to incredible transformative research on childhood adversity and mental health for youth and families impacted by war and displacement. Her work is translated into system and public health impacts for war-impacted refugee communities in Africa and the US. Dr. Betancourt is the inaugural Salem Professor in Global Practice at the Boston College School of Social Work and is also the director of the research program on children and adversity. She's led intergenerational longitudinal survey study of war-impacted youth in Sierra Leone, which has been studying the impact of conflict and trauma on youth since 2002, and now is approaching 20 years of follow-up, which has been incredible. This work's led to understanding of resilience and protective processes and child and adolescent mental health, and it serves as the foundation for her youth readiness intervention, which is being scaled up in youth employment programs in collaboration with the World Bank and the government in Sierra Leone as part of her NIMH-funded mental health services and implementation science research hub called Youth Forward. Dr. Betancourt has also developed and evaluated the impact of family strengthening intervention called Segura Miriango, which is a home visiting early childhood development intervention for HIV-impacted youth and their families. And she will be talking more about that in today's talk. That work is funded by the LEGO Foundation and is part of a multi-level strategy to scale out interventions in Rwanda. And domestically, she's been engaged in community participatory research on family-based prevention of emotional and behavioral problems for refugee and children and adolescents resettled in the US. She is written extensively on mental health and resilience in children facing adversity. Her work is published in Child Development, the Journal of American Academy of Child and Adolescent Psychiatry, the Journal of Child Psychology and Psychiatry, JAMA Psychiatry, AJPH, and PLOS ONE. She's been profiled in the New Yorker, National Geographic, NPR, CNN, and has interviewed in Larry King. Please welcome Dr. Theresa Bettencourt. We are so excited to hear your talk.
Thank you so much, Vicki. And I just want to thank all of you for having the chance to come and visit you in person, even though there's so many folks I've been able to meet in person and online. I love the hybrid approach. And I just want to say what a big fan I am of Vicki and her work, especially as an implementation scientist and one of the leads in this field. So it's really an honor to come and present some of the work that we're doing and get thoughts and feedback from all of you. So I thought, given that CUNY is such a leader in implementation science and global health and mental health, that I'd talk today about some of our work in scaling out home visiting intervention, both to promote early childhood development and intergenerational violence, especially in post-genocide Rwanda, and the partnerships that this takes. And so I'm going to, in my talk, just give you a little bit about the intervention itself, but also some of the context and the background that led to this, an initial randomized control trial, but how we haven't stopped at the randomized control trial and how we've really been thinking about the science of scale and sustainment and some of the next directions for family-based prevention within our lab and how we're thinking about that. So I wanted to also tell you a little bit about my own motivation in doing this work. It can be said that I'm from a low resource setting. I was born and raised in Bethel, Alaska. If any of you know Alaska, this is in the interior on the Yukon-Kuskokwim Delta. It's mainly native Yupik peoples who live in the region. And it's a region that can face extreme adversity. I've seen 90 degrees below zero, but it's also a place where there's tremendous collectivity and a culture that's very rich, and a place where I learned a lot about cultural humility. So growing up there, people wear many hats. My father was the science teacher, the math teacher, and the fire chief. My mother started one of the first early childhood development programs, and worked with infant learning program. They actually named the ECD center after my mother. And I had skills like catching fish, as you see here, through ice fishing. But I learned the Yupik language. A lot of my babysitters and early friends were from that culture. And I think it really influenced my approach to thinking about collectivity and coming together to face challenges like extremes, including the year our town generator caught on fire and people were at risk of freezing. And so those of us who had wood burning stoves took families into our own homes until they could restore power over several days. So it's a place where we all had to pull together and work in partnership to really make it through hard times, and also to celebrate a beautiful culture. And I hope I've been able to carry that work over into what I do globally, which is always through partnerships. And these are just some photographs of our teams of experts in the home visiting intervention in 3 districts in Rwanda and some of our training coalitions. And so I'm talking today, but really this is the work of this amazing team at Boston College, our different postdoctoral fellows, our research professors, associate directors, statisticians, and then also Dr. Vincent Sezibera, who is the head of the Center for Mental Health in Kigali, Rwanda, at the University of Rwanda, and Joseph Kalisa, our capacity building coordinator, and our field-based staff, Ursula, Gabby, and O'Day, who've been working with FXB Rwanda, our local partner, and the government on the implementation. So certainly this is not just my work, it's really this huge team. And so this was really the shot heard around the world when it comes to child development. This is from the Lancet series on early childhood development, and the paper by Sally Grantham McGregor, that over 200 million children under the age of 5 are not fulfilling their full developmental potential. And this comes to statistics such as children ages 36 to 59 months who are not developmentally on track in domains of literacy, numeracy, physical development, cognitive development, and learning. And those estimates were updated more recently in 2017 to be estimated at even greater numbers, at 249 million children. And so when you look at where these problems are concentrating, it's often in sub-Saharan Africa, where far too many children are failing to reach their full developmental potential. Now, you lay that over the top of what we have in terms of violence around the world and children armed conflict, and look at the statistics. And again, we see risk factors coming together. Globally, at the end of 2019, it's estimated there were nearly 80 million forcibly displaced people, nearly 46 million internally displaced, over 26 million refugees. And time again, we see in war zones that the numbers of individuals under the age of 18 are quite large. So these are problems of children, youth, and families, with 40% estimated under the age of 18. And Unicef now estimates the number of children living in conflict zones has risen by over 74% in the last decade. So in our lifetimes, we're facing the largest humanitarian crisis since World War II, as we're overlaying this with the underdevelopment that we see in so many parts of the world, very concentrated in sub-Saharan Africa. And these disruptions to early development, to mental health, translate into huge problems for societies, families, and individuals. So we know from research, and this is from World Bank data, that young children who are physically stunted as a gross indicator of underdevelopment or falling behind in cognitive, linguistic, or socio-emotional development are much more likely to enter first grade late, perform poorly in school, repeat grades, drop out of school before they finish primary school, have poor physical health and mental health over the life course, engage in more risky behavior, including sexual risk-taking behavior, teen pregnancy, sexually transmitted diseases, and be overall less productive and have lower earnings. And so these issues of underdevelopment and trauma in children are really important for governments and development actors to take note. And I was influenced very early on in my career by thinkers such as Julius Richmond. Dr. Julius Richmond was the mastermind behind the scale up of the Head Start program in the United States. He's former US Surgeon General, and he wrote eloquently about this interrelationship or the virtuous cycle between the evidence-based, political will, and then inform public policies and having social strategies to enact much more evidence-based policy to influence the lives of young children as they develop and face adversity. And so how do we do that globally? And what do we know? Well, there have been a number of studies looking at the long-term effects of coming in early with early childhood development oriented interventions in lower resource settings, some from the United States. So some of the most famous studies come from examples like the Perry Preschool Project, which started in 1967, which was a study of high quality preschool education. They had a randomized control trial of 128 3 to 4-year-old African-American children living in poverty. And they found over the life course by age 40, there were large effects in terms of educational attainment, income, criminal activity. And this is one of the longest running longitudinal studies looking at the importance of preschool education on long-term positive life outcomes. There's also the Abecedarian Project from 1972, which looked at full-time, high-quality educational intervention in a child care setting starting in infancy through age 5, and they've had follow-up studies of multiple years. They, again, observed positive long-term effects of this intervention, particularly to surmount some of the disadvantages of poverty. And globally, a very influential study has been the Jamaica Rejob study, which began in 1973, which provided play-based home visiting and nutritional supplements to infants who were identified as being stunted and really focused on those first 2 years of life. And the Jamaica Rejob program observed improvements in child language, cognitive outcomes, fine motor outcomes, and socio-emotional skills. And they also observed, again, longitudinally effects on adult outcomes, including educational attainment, college participation, employment. And now this program has been scaled up and revised and adapted to several countries. It's rolled out as a national policy in Peru, Jamaica, as well as Bangladesh. And also coming out of lower resource settings, Kuna Mas, which is another ECD program, more than a crib, provided home visiting parenting programs that were focused on ECD in Peru. And impact evaluation showed significant effects on child development, cognitive development, communication. And there's now a national scale up underway within the Peruvian government, providing care to more than 170,000 minors from 0 to 3 years of age. So lots of exciting work, but where's sub-Saharan Africa in all this, given the risk factors I just showed you and the overlap of things like armed conflict? And so we in our own small little way are trying to contribute to closing this gap between what we know about the risk inherent in disadvantage early in life, especially trauma exposure and violence exposure, and what's truly done on the ground, especially in low resource settings. So our research program on children in adversity is really focused on identifying factors that contribute to trajectories of risk, as well as resilience in children and families that face adversity globally. And in doing this, we take a strengths-based focus. We're not focused just on deficits, but really on capacities. And how do we learn about those locally and unlock the potential and protective factors that can come into play in the lives of children and families. And to see the highest quality, most effective programs used, even in the lowest resource settings. And this is globally, but also here in the United States. And so I'll just tell you a little bit about our work. We've been, as you heard from Vicki, involved in longitudinal and now intergenerational research of the impact of armed conflict on children. In Sierra Leone, now a 20-year longitudinal study. The most recent wave was funded by the National Institutes of Child Health and Human Development. We're now in discussion with NIMH about a 5th wave. I've also worked in war-affected regions in the Russian Federation, the Kosovo crisis, Ethiopia, Eritrea border, and northern Uganda on the topic of child soldiers, as well as war-affected, internally displaced populations and bringing evidence-based interventions to bear. I'm going to really focus in today about intergenerational violence in early childhood because of the implementation science features of what we're able to do in Rwanda. And then I'll also talk a little bit about some of the work we're doing on promoting family functioning in refugee families coming back to the African diaspora here to the United States and working with Somali, Bantu, and Bhutanese refugees in a community-based participatory research project of a family strengthening intervention, which is a lot of the same content that you'll see in the Rwanda intervention now adapted here for refugees in the United States. And so one way that we always think about our work as we are coming to cultures to which we're ultimately outsiders, we don't know the culture, we don't speak the language, it's not okay to just rush ahead with a survey. We're really a mixed method shop. And early in our work, oftentimes we're starting very carefully with formative work, oftentimes qualitative work, to understand from the ground up, how do people around here think about these constructs of mental health in children in non-stigmatizing ways? What are the terms they use? How do we think about what's good parenting here? How about protective processes that can make a difference in shaping the mental health trajectory of children who've gone through adverse situations, or promoting child development? And then we use that qualitative data to select measures or adapt existing measures, or in some cases create new measures when there aren't really instruments out there that capture locally what's important, and then validate these tools. And now we've learned about strengths that we can also think about the active ingredients of intervention models that could be a good fit to the setting, and that we know from the evidence base have the potential to have impact on the kind of outcomes we're looking at. And we then implement these interventions using the most rigorous designs possible, randomized controlled trials, and now moving our work much more towards these questions of scale and implementation science. And these are really important constructs. As all of you know, we have a very leaky pipeline when it comes to the dissemination of evidence-based practices. And this is a very famous paper from Vallis and Boren in 2000, looking at just NIH-funded research, that it takes 17 years to turn just 14% of original research to the benefit of patient care. And this means we need to think about implementation science a lot earlier in the process, and begin to design for implementation and think about questions such as, who's going to deliver the intervention? What's its fit with the patient population, with the available providers? How will we go to scale given limited mental health professionals at a high level of training in these settings? How can we do things that involve task sharing? And then that means we really have to think about issues of quality improvement as we go, and building these tests and ways to think about adherence, fidelity, and what are the mediators and moderators of intervention impact. And that means also thinking about hybrid designs, such as studying both effectiveness, but also implementation at the same time. And there's so many places to lose impact during implementation. A lot of our global work, and even our work domestically, we see this sort of train and hope approach to interventions, instead of really thinking about fidelity. How do we ensure the core content that's evidence-based is truly delivered as intended? And as you expand practices, there's drift that comes. And so how do we keep that focus on quality as we work with vulnerable families, as we expand the use? And so that brings us to the Sugiro Muryango example. And for those of you who don't know Rwanda, we're in East Africa, neighboring the Democratic Republic of Congo, Tanzania, Uganda, and Burundi. And geographically, Rwanda is a small country, but it has 13.4 million inhabitants. Again, these issues of children, youth, and families loom large, 53% less than 20 years of age. And Rwanda is making strides in public health. They've brought down their rates of under 5 mortality, of maternal mortality, but they have some areas that continue to be a challenge, including one of the highest rates of stunting as a broad measure of underdevelopment in all of sub-Saharan Africa. And you've got a country that's lived through the genocide of 1994, the HIV/AIDS epidemic, and you have these pockets of extreme poverty, loss, and trauma, and now overlay the COVID-19 pandemic that all of us are experiencing. But strengths in working in Rwanda are the political stability. You have a strong government with fiscal and administrative decentralization, a lot of effort in strengthening local government. And early childhood development has a tremendous amount of political will. It's actually been written into the economic development and poverty reduction strategy. They recognize the importance of starting early and thinking about the home environment. And there are a lot of other initiatives related to a focus on children and youth. There's the Generation Unlimited Youth Initiative, which is focused on ensuring that all young people ages 10 to 24 are in school, in training, or employed by 2030. And attention to violence, such as the Isanje one-stop centers, which provide supports for children and families exposed to sexual assault and other forms of violence. So there's a lot of good going on in Rwanda that are sort of the grains for doing this kind of work. And this political will, you see here, this investment by the government on the cover of the local newspaper, 5,000 early childhood development centers to be established. And there are these beautiful early childhood development centers at every district now in Rwanda. And we had started focusing not just on the center environment, but the home environment, first in the context of HIV and AIDS related work. So when I first started in Rwanda, we were working, I was at the Harvard School of Public Health on the faculty. We were working with Partners in Health, a major global health NGO, and the government of Rwanda on thinking about parenting in the context of adversity, but in this case, in the context of HIV and AIDS. And we had taken an evidence-based family strengthening model that had been used in a range of different cultures, including with Native populations, scaled up in Costa Rica, used within a number of low-income populations in the United States, and adapted it to households affected by HIV and AIDS, and done this with Dr. Sezibera. So we had a parenting intervention we'd already tested and saw that it reduced depression in children. And we've been writing about the opportunity to integrate violence prevention into early childhood development globally because of all the political will, because of those numbers like what I showed you from the World Bank and the work of Jim Heckman and others who've really drawn attention to the importance of early investment in economic returns later in life and promoting population health. But oftentimes when we talk about violence in children and underdevelopment, it's the same families we're talking about, the same services systems, even the same sort of sectors of workers. So why aren't we bringing these things together? That's a lost opportunity. So to get involved in the work, we jumped at the opportunity to work with Unicef and the government of Rwanda on a national early childhood development baseline assessment, where around 10 districts in Rwanda, we sampled 884 caregiver-child pairs and did assessments that really focused on household characteristics, caregiver characteristics, caregiving practices, and then child indicators of development, nutrition, and health. And you see this extremely cute Rwandan child being measured for length. And so those basic anthropometrics. But one thing that we saw right away were issues related to violence. And when it came to harsh parenting, we saw that nearly 20% of children under 1 year of age were exposed to some form of violent discipline. And then when it became children ages 2 years to 3 years, 80%. And we also saw in our data that more than a third of caregivers felt that physical punishment was necessary in order to raise children well. So we started to think about these issues of intergenerational violence. And this was really the genesis of the Sugira Mayango intervention. So we had the backbone of that strengths-based parenting intervention from HIV, but now we weren't specific to HIV. We're thinking broadly about children in poverty. And so we had the backbone of a focus on conflict resolution, stress management, problem solving, all to reduce risk of family violence. We were already inherently working with all family members, not just the mothers, but also the fathers. And this is a flexible intervention because it's done with home visiting, with a local non-specialist, a community health worker type. We can work with any kind of family. We can work with just mothers, just fathers, aunties, uncles, grandparents, any kind of configuration. And we added in WHO Care for Child Development standard content on early stimulation, nutrition, hygiene, and another important feature, not only the male engagement as well as females being a focus, we also really take an active coaching approach. So I spent my sabbatical at the Harvard Center on the Developing Child developing this intervention. So it's not about the home visitors playing with the children. It's about them coaching the caregivers in those serve and return interactions and nurturing care and the importance of play. And at every session, we have a 15-minute play activity where the parents are coached in those joyful interactions and just the resources they have locally, being able to encourage playful interactions with their young child. And so it's meant to be complementary to all the other government initiatives around community sensitization, around home-based childcare initiatives, and ECD centers. And the platform for delivery, when we talk about implementation science, becomes extremely important. So how are we going to reach the numbers we need to reach when we talk about adversity in Rwanda? Well, adversity in Rwanda is already a target of the poverty reduction strategy. Rwanda has a program called Vision Umurenge. It's their flagship social protection program. And it has goals where we can find a win-win. Their goals are to reduce extreme poverty, to promote gender equality. We're already doing so much around that, and to increase attention to social safety nets. And for us, we're looking to support responsive parenting, promote ECD, prevent violence. And the win-win is we already are identifying through this program the most vulnerable families. What Rwanda is offering them is the Cash for Work program. So rather than cash transfers, the government has been really remiss to not have people engaged with some skin in the game. So oftentimes they ask them to do some kind of social programs work, and these can involve very hard physical labor, you know, building a road, digging a ditch. But for young children, that has real complications for what it means for the parents needing to work to get that cash transfer. And so how can we make these more family friendly? But it's also a way to identify where we have a constellation of those risk factors of risk for violence, of family, social, and economic stress. So early on, we did the formative qualitative work. We developed tools. We began to look at evidence-based manuals, our prior manual. The manual was actually, it used to be 25 sessions long, and the government said, there's no way that'll be scalable. You have to be able to bring this down to the core sessions. We've reduced it to 12 modules of home visiting. We had 2 pilots, again, thinking of do no harm as our operating principle, and then a cluster randomized trial. I'm going to show you the results of that. But then moving beyond that, how will we scale? And now we've moved from a workforce that we got to pick into a government pre-existing workforce, the Friends of the Family Child Protection Workers. And so, as I mentioned, there's a 15-minute play session that's active coaching of the caregivers at every session. And we're making local toys. We're not bringing in fancy materials. You can make very simple soft toys and rattles and pull toys from things found and sourced locally. That's very empowering for families. We also do a lot around father engagement and male caregivers of all types. And we really focus on flexible scheduling, showing up when the dad's, you know, done with work, has had a meal, can be engaged. And in our imagery, we always really are modeling how important males and females both are to the home environment, being a healthy place where the baby can thrive. And through this approach, we've been able to engage male caregivers at a very high rate. And on average, men in our intervention, when they are in the picture, they have completed 70% of all the modules, which is really a testament to our local team. And you see here some of the imagery we use, both with the mothers, but also the fathers, very much at the forefront. Because a lot of the families we work with maybe haven't had as much education or access to education, we use a lot of local proverb to communicate core messages in ways that are culturally resonant. You see here some of the core proverbs that we integrate within our manuals. These are, you know, Rwanda has a rich storytelling tradition and use of proverbs and poetry. And so these are nice ways for people to integrate the content. As I mentioned, violence reduction is a big part of what we're focused on in addition to promoting early childhood development. So we're really looking at nonviolent alternatives to disciplinary practices, to reducing conflict in the family, and to problem solving. And so here's our theory of change. We're really focused on the Ubudehe 1 families, because that's where we know vulnerability is concentrated. We could work with many more families, but that has a cost. And focused on those who have a young child under the age of 3. From our formative work, we know the risk factors of limited information about children's development. People would say things like, why would I talk to a young child if they're not talking yet? I look like I'm a crazy person. So, you know, just helping people understand the importance of early stimulation. When there's hard physical labor needed, sometimes children are being left in the care of other children or neighbors. There's limited stimulation and learning opportunities. For families in extreme poverty, it can be a real crisis to think about the future. You're just focused on surviving in the now. So helping them begin to think about, you know, what it's going to take for that young child to thrive and eventually, you know, not have a real cycle intergenerationally of poverty in the family, reducing social and economic stress, and also reducing risk of family violence. So our core components include this active coaching and learning on nutrition, on health, on hygiene, coaching and responsive serve and return interactions and the importance of play, father engagement and all of that, building resilience and coping skills, including a family narrative, which is something that came from the intervention with HIV and AIDS affected families. We've kept that in, which is really a strengths narrative about the things the family has been through in the past and what helped them. What are the unique resources in that family, and honoring that. And then building skills in problem solving, and also navigating both formal resources and informal resources. So Rwanda has, you know, intensive acute feeding programs for malnutrition. They have a Mutual national health insurance program. And sometimes families aren't knowing about those programs, aren't benefiting from them. So we can help them navigate, because the home visitor gets to know, the family gets to know what they are accessing and what they're not. And also they can work with local leaders. So if there are issues like family violence, oftentimes families are known to local leaders. And so we don't really take a policing approach as much as a problem solving approach when it comes to family violence involving local leaders. And lastly, just building these skills in emotion regulation, self-care, stress management, and alternatives to using harsh punishment and violence in the household. And so pre to post, we hope to see changes in caregiver behavior and reductions in violence and a safer home environment. And then we, 1 year out, we'd hope to start to see changes in, the child development indicators and sustain those impacts on violence. And I'll show you the results of those 2 studies. And now we're planning a 3-year follow-up as children are transitioning to early childhood programs and pre-K, school readiness, language, behavior, as well as social emotional skills in the children who've gotten home visiting compared to just the Catch for Work program. So here are our 12 modules. I won't belabor this because I sort of touched on this in the conceptual model. But the trial itself had to be very creative, because you had the rollout of the Catch for Work program, or we call it the Public Works program. So the classic Public Works, as you see in this cluster randomized design, we had a lot of that was available. So we had 121 clusters, and these are about 5 families around 1 home visitor that would be considered a cluster. We had to draw them so that they were contiguous and not overlapping. And then we had this expanded, more family-friendly public works program that were jobs closer to home, maybe less hard physical labor, learning to cook at a child care center, things like that. And then we had some regions that had both those programs. And so we drew our clusters, 284 clusters were randomized in this trial, either to just the usual public works, expanded public works or classic, and then those programs plus Sugit or Moyango home visiting done by a non-specialist. And in terms of our measures, we are looking at outcomes such as child development using the ages and stages questionnaire and the Malawi developmental assessment. We have indicators of caregiver mental health from work that had been done by Paul Bolton and others on adapting the Hopkins symptom checklist to Rwanda. And on caregiving, we have the home observation or the home inventory, the observation for measurement of the environment, mother-child interaction observation. We're now working to develop a father one, which is so important given our theory of change, and a parenting questionnaire. We have modules taken from the multiple indicator cluster survey, Unicef, on child discipline, and then indicators of child health, nutrition, water and sanitation, hand washing, water treatment, cooking practices, and then the anthropometrics, height, length, weight, middle arm circumference, MUAC measures, and then a dietary recall and dietary diversity, what kinds of foods, and health indicators related to fever, diarrhea, cough, etc. And I mentioned task sharing. It's really important, all the work that's gone before from researchers such as Vikram Patel and others, indicating that behavior change, mental health, parenting, and ECD interventions can all be done with effectiveness by non-specialists if they receive excellent training and supervision. And so it's really been an innovation in global health. And so when we picked our home visitors, we were able to go through a 3-tiered selection process. They had to be in good standing in the community, nominated by people in the community. Then we did telephone interviews, then in-person interviews, a 3-week training. And our supervision was done in person, also group supervision, and then we would have telephone check-ins. And so this is just a sense of our sample demographics, both from the caregivers. They're about, over 35 on average. 63% were married or cohabitating, but a large portion were also single-headed households. We have a range of relationships with the child of those enrolled in the study, from bio mom and dad to aunts, uncles, and even grandparents. And in terms of educational attainment, this is Ubadehe 1, right? This is our sample in the trial. So we have 23% have never had access to education, and 48% under 6 years of schooling. When we talk about the children, we see average age was about 22 months, half of them were female. And again, this is Ubudehe 1, so we're seeing even higher levels of stunting than in the general Rwandan statistics. So 48% would meet criteria for stunting, also a small degree of wasting, high degree of underweight. And then just using this Unicef screener, we also saw a lot of kids would just meet criteria for being behind in their development at 30%. And 47%, so again, much higher than that Unicef survey, were exposed to some form of violent punishment. So this gives us some indication we're in the right zone when talking about who really could benefit from this intervention and thinking about targeting the intervention, but that's not to say that that's the only place we could use it. On caregiver mental health, again, we saw very high rates on the Hopkins syndrome checklist of depression and anxiety-like problems, and also so 45% meeting those sort of standard cut points, and almost 20% meeting criteria for likely post-traumatic stress disorder. So mental health is a big issue. A high accumulation of daily hardships. We talk about social determinants. If you look at issues of not being well employed, not having enough money, having death in the family or injury, very high rates in these families, in addition to cumulative exposure to hardship. And then in war-related trauma or genocide-related trauma, this was sensitive to ask about, but we used a tool that had been used before in some genocide-related research. And we found that 52% of the sample had experienced at least one significant war-related trauma. So now I want to talk about the results of the trial and then talk a little bit about the implementation science before I run out of time. So this is our first paper. It was the pre to post findings. And we did see, for those in the intervention group compared to clusters that just got the usual VUP program, a significant impact on stimulation in the home, on the home inventory, an increase in playful activities in the last 3 days, a significant increase in dietary diversity and consuming more food groups, and also on health-seeking behaviors, we saw increased help-seeking from the parents, both for diarrhea as well as for fever. Then looking at the household environment, we saw significant decreases in children's exposure to violent child discipline. And also on intimate partner violence, mothers reported a significant decrease in intimate partner violence if they were in a cluster receiving intervention. We also saw, and this was, very general, not specific mental health components in this intervention. We did see a significant decrease in depression and anxiety, both in the mothers and the fathers receiving the intervention, which is a really exciting sort of secondary effect. 1 year later, we came back and looked again at these outcomes, especially interested in the child development outcomes on the ages and stages questionnaire. We saw significant impact on gross motor skills in the children receiving the intervention. We did not see an impact on fine motor outcomes, but we did see significant impacts on communication, problem solving, and also the social emotional Z-scores on the ages and stages questionnaire. And we were excited to see that the violence reduction also had sustained 1 year later, that we still had a decrease in children's exposure to violent discipline and a reduction in intimate partner violence 1 year later. And we saw this triangulated in our qualitative data, mothers saying things like, Sugita Muryango boosted my children's communication, how to behave when having conflict with each other. When the child's sick, I immediately go to the health center. Before, I used to give them traditional medicines. It also has helped build our hope for the future. Everyone's saying my child is sharp due to Sugita Muryango. Or this father who said, we normally have stress caused by our daily hardship, but through the intervention, we learned how to manage the stress caused by poverty. Personally now, I couldn't hit my wife or my child when I'm stressed. I go look for a friend or talk to them instead of shouting at home. When you look at the number of sessions and the impact per session, we're right in line with a lot of those sessions that are, a year of home visiting in terms of our impact, which is really exciting because we were asked to keep it, light and not have something that the government couldn't afford in the future. And we've done a lot on the cost of the intervention. If you look at it in our research, it's certainly a lot more costly, or if it's managed by an outside NGO. But when you start to look at integrating it into the government system, we can actually bring down the cost a great deal. So it's under $200 per family, $17 a session. And then when you look at the outcomes we're having in terms of cognitive development and what that means for future school success and future earning, as well as reductions in violence, we can run some estimates about the return on investment. And we're seeing that given those outcomes, the return on investment is likely for every dollar spent somewhere between $3.8 to $5 of return. So those are really important data for talking to the government and talking to development actors. But how would we scale this? And that's really been the focus of what we call the Play Collaborative, which is now shifting the intervention from the research sort of methodology to existing workforce within Rwanda, using cross-site learning and a learning collaborative type methodology across 3 districts, Rubavu, Ngoma, and Nyanza. And again, targeting Ubudehe 1 households in the VUP, but using a workforce that was developed in Rwanda as they deinstitutionalized in orphanages around the country. We've learned a lot about the science of institutionalization. So Rwanda, in shutting down a lot of the orphanages, had this workforce of the Friends of the Family Child Protection workforce. There's 2 in every village, 1 male, 1 female. This study is now moving the intervention towards that workforce done by the government in an attempt to reach up to 10,000 households with cross-site learning. And to do this, we work with FXB Rwanda, who's our partner for implementation and doing all the training and capacity building. We've had amazing partners from the Lego Foundation, Grand Challenges Canada, Elma, Oak, and USAID, as well as the Rwandan government and the National Child Development Agency in the country. So the Play Collaborative is really focused on transitioning the evidence-based practice away from us, the developers, to the government and its partners and the local workforce. And to do this, we need the buy-in at every level of national government and local government, but also civil society. So women's and men's associations, community leaders, community health centers. And we do this through having our experts who've done the intervention in the past now becoming cell mentors or experts in a cascade model to train the new home visitors who are the Friends of the Family Child Protection workforce. We call them the IZUs, the Inshuti Zumuryango, using the local term. And there's a shared charter. We all commit across the 3 districts to this quality improvement process, to using plan, do, study, act cycles, to continuous training and on-the-job learning. And also have now lately with COVID-19 been using a lot more technology to support transparency and innovation and communication. And so I mentioned this requires really thinking about multi-level buy-in to shift this to local ownership. We're guided by Greg Aaron's EPIS framework of implementation science that moves from exploration and preparation to the implementation factors and thinking about mechanisms for sustainment. So you've got inner context features like how easy the intervention is, how brief it is, how it can be done by lay workers, the fit to the local population, and then outer context policies, the financing, the political will, and then bridging factors like our community academic partnerships. We focus a great deal on fidelity monitoring. So there's a weekly Play Collaborative meeting, which is really focused on plan, do, study, act cycles and problem solving. We do a lot of observation of the new home visitors. So a cell mentor is able to come in and sit in on some of their sessions with permission, give in-person feedback to improve their practice. We've done some video data collection where we can compile some of the themes confidentially across all the sites to share them at Play Collaborative meetings. And now, most recently, through our trainings, we've been able to train nearly 2,600 in Inshuti Zumuryango in these 3 districts with 10-day trainings, 3 rounds of training each, 124 training sites. And they learn through role play how to do the intervention, how to actively coach the parents, how to look at issues of hygiene, nutrition promotion, and stress management, conflict resolution, and how to screen and refer for other health problems and developmental delay included in that, and these concepts of gender, which are threaded throughout all of our interventions. We've also done a great deal of training with the government stakeholders. So now, most recently, we've trained nearly 6,500 government stakeholders in all 3 districts, and this is village sector affairs officers who are in charge with what's going on at the local level, local leaders, ECD focal points, community health workers, people from the health centers, health center representatives, and also civil society actors. And they don't learn to do the intervention, but they're learning the broad topics and the goal of the intervention and the Play Collaborative engagement strategy. And they're a part of that. They come to the meetings. And so with COVID-19, we've had, of course, as everyone had, all sorts of challenges with safety and access. We had to move a lot of our training away from these big meetings and trainings to WhatsApp in some periods and keep our training going using digital technology and check-ins with the team. And they would be reviewing and doing smaller role play and then bringing questions to the broader group. We also, with our partners were able to procure PPE and start to think about ways that we could still do some of the home visiting capacity building, following the government standards and aligning at every step with government protocols. And this helped us really deepen our partnership with the Ministry of Health. So early on, we're seeing feedback from the Play Collaborative. People talk about this as a really excellent strategy for raising awareness of local leaders in early childhood development and violence reduction and getting their investment in the program, a time for us to engage in problem solving and also remind the home visitors about adhering to the evidence-based practice and how to do that and get guidance from one another. And it's also a chance for us to problem solve and find solutions to different implementation barriers as we've gone. And in terms of political will, I think letters of appreciation like we've gotten from each district really speak to how important and transformative the intervention has been in each of these 3 districts. And these are things we can bring back to the central government and to the donors in talking about further investment. Just like many of you here at CUNY, we've also done a great deal on the use of technology. We've been working with the Center for Mental Health and the Computer Science Department at Boston College, but also University of Rwanda, and Makefully to create a digital dashboard. So you've got a way that we've been co-designing this with the home visitors. So in the future, the manual doesn't have to be paper, it can be on a smartphone. There are training videos and resources on there if they need to refresh. And it's also a way to capture the data and even have some very transparent sharing of how are we doing across the different sites on quality indicators. We've also done a tremendous amount on capacity building and mutual learning. We don't see ourselves as just the experts, and the Rwandans are going to learn from us, that we have a lot to learn from Rwandans. And we've started a series of research and writing workshops to really bring along trainees and faculty in Rwanda to lead up papers, publications, dissemination of this experience. We have an annual research conference and interest groups on gender, on child development, on mental health and trauma within the University of Rwanda. So just to wrap up, I want to mention this same kind of concept of strengths-based family home visiting done by people who come from the culture has carried over to our work back here in the United States with the African diaspora, first with refugees from Somalia, Somali Bantu refugees, and then expanding to other refugee groups, including Bhutanese refugees working in Chelsea, Massachusetts. That when we first started the project, we started in Chelsea, and then with 2 different grants from the National Institute of Minority Health and Health Disparities, have been able to take the same strengths-based model and adapt it to be done by peers, by refugees, for refugees. And we've published in the Journal of Adolescent Health a pilot study on our impact. We're seeing exciting outcomes both at the child mental health level, improvements in symptoms, but also improved family functioning. And we're now finishing a hybrid trial, effectiveness and implementation, studying this done again by peer providers through home visiting, and are again seeing those results replicated, but also testing a strategy for how we could link this to community health centers where community health workers are available, but they're not oftentimes doing family-based prevention and behavioral health. And we're now in discussion with the Office of Refugee Resettlement about doing this with Afghan special interest visa holders and humanitarian parolees, as we're seeing a large Afghan resettlement in the United States. And so there could be the possibility of a multi-state learning collaborative on that same evidence-based family home visiting intervention in the future. So just to wrap up so we can have a little time for questions. I hope I've been able to convince you that we're really seeing a lot of progress in the science on home visiting and violence prevention, but we really need investments and leaders like you all in implementation science to advance the use of evidence-based practices at greater scale. There are really exciting opportunities for integration. I've talked today about integrating into the social protection system. There are ways we can integrate evidence-based behavioral interventions into nutrition programs, into, as children get older, into educational systems, into health systems, primary care. But we really need to focus on the enabling environment, the policies, the financing, and policymakers need information on that return on investment. And to do all of this requires strong multi-level partnerships and mutual learning to really take the kind of work we do to greater scale. So on that note, in a shameless plug, I'll let you know that we're hiring with all of this expanded work. We have a position for an associate director, research clinical professors, capacity building managers. And I know there's so much talent here in implementation science. It's been an honor to meet all of you and see the great work going on in CUNY. So with that, I'll wrap up and open it for any questions.
Thank you, Theresa. Wow, what an incredible body of work you've created over all these years. It's really great to see, just the longitudinal work you've done and have that, transform into intervention work that has made policy impact, system change, and to be able to scale up at the level that you've scaled up, I think is just so incredible and really speaks to just how great this work is and so innovative. And the work on engagement with fathers, I think, is just so needed here in the U.S. as well, and hasn't really been done very well in the family strengthening intervention world, I think. And so it's really great to see that. I want to see if anybody has any questions. Please feel free to put them in the text or in the chat, and I can read them out. Or you could also turn your mic on and ask the questions as well.
I have a question.
Mhm.
Good afternoon. I would like to ask the speaker, is there any way that people who attend can get a certificate of attendance for this webinar?
For
Oh,
this,
that's on you, Vicki.
yes. So I don't know that we offer that for the grand rounds. So I can check with those who organize the grand rounds to see if that's something that we provide, but I don't believe that that is something we generally provide. If you can contact me over email and I can follow up on that for you.
Thank you.
Thank you.
But that was very nice, a great topic. It's very important, this type of topics to
Thank you.
engage in. Thank you.
We do have a question from Andrea Isabel Lopez.
No, I said that was a very nice presentation, a great topic to strengthen family
Mhm.
around the world, globally. I think it was really a great work,
Thank you.
great presentation. Okay.
Thank you. So we do have a question from Andrea. Her question is, how do you put in practice asset-based approaches as you engage with different groups of stakeholders? And how do you sustain the longevity of these practices beyond the project funding?
Yeah, I think an asset-based approach or a strengths-based approach is really fundamental. And I think one sort of orienting principle that has been so important with our programs of work have been to stay over the long haul and to go deep, to try to learn local terms, learn about who are the key stakeholders, find champions. And I would say all of our projects are usually on this spectrum of community-based participatory research with the goals of more mutual learning and exchange. And that usually means that we're setting up advisory boards from very early on in the project of youth themselves and parents, but also policy stakeholders so that we get their interest and engagement very early on. And then, thinking about sustainment has to be very intentional. So you have to plan the project from the very beginning, thinking about not just what could work, but what could work at greater scale. What are the workforce, human resources for health? Who could be the systems? What could be the systems we're going to link to that could scale? And then how could this be paid for? How could we finance this? And what would be the policy structures to make that possible? And so I think in Rwanda, we've been able to demonstrate one approach of doing that, part and parcel with groups like the World Bank and USAID from the very beginning. And now the work that we're able to do with the government on handing over and capacitating local leaders to be experts so that it doesn't rely on folks in Boston always being the trainers or coming out or even being a part of future efforts to scale it beyond this demonstration of scaling it across 3 districts. So I think it takes a lot of intentionality, it takes partnerships, and it takes a community-based participatory research orientation.
Mm-hmm. Mm-hmm. Yeah. So related to that, as you mentioned the voltage drop and how that happens, and so sustainability is very challenging because the strength of the intervention oftentimes drops. Once we don't have a lot of resources in place and infrastructure in place. And I was just wondering, from all the scale-ups that you've done, what are the factors that contribute most to the voltage drop that you've seen, or factors that promote the sustainability?
Yeah, that's a great question. I think this issue of intentionality and taking it seriously, because I won't mention any names, but we have met development actors who just basically assume poor implementation You know, so they say, you know, assuming poor implementation quality, here's what we think we can get. And I think we really believe in, let's assume that we can do better than that. Let's assume from the get-go that we can take quality seriously and bake quality into how we do the intervention. So we would never just train and assume that that's enough, right? That the supervision and the quality improvement, the problem solving and the ongoing on-the-job learning and then exchange across sites, so they're not working in isolation, really matter. And when you don't do that, you know, you recreate the wheel, making the same mistakes time and time again. And I think it looks different in setting to setting. When we've done work like this in Sierra Leone, we were so off the grid. You know, you can't do the kind of cool things we can do with learning collaboratives here in the United States, where you can have Zoom meetings or virtual meetings. You know, we had to like take the expert and have them base out there in the very far remote areas of Sierra Leone because we couldn't even get phone network. We couldn't upload data. But we do, you know, in this project in Rwanda, have a better network, and, you know, but we design our data systems to focus on quality indicators, you know, so we can, if this intervention is done well, if there's a male in the household, the male should be involved. That's a basic data point we can collect. And how are we doing across districts with achieving those goals? And then other goals of, you know, are they making sure people are on the national health insurance? Are they reviewing the hygiene practices? Have they done the module on conflict resolution? Have they done self-care? You know, so there are ways in which we can bring more transparency and data to bear and bake it in so that when we give it to the government, we're not just giving the intervention, we're giving it with the supports and the tools to make sure that quality is taken seriously.
There's also a question here on how to convince policymakers on the return on investment when the outcomes seem so long-term.
Yeah, I think the first thing is just having that kind of data. And I think, you know, to run those calculations on return on investment, you're talking about the phenomenon of child development. So the only way to even make those arguments is you have to find data on the mechanisms that link what you're doing now to eventual school success, because all the data is on higher levels of education. If what you're doing now means kids stay longer in school, that's going to lead to knock-on effects in terms of later employment and even some of the other outcomes we see related to health. And so all the strong evidence is there. So we have to be able to find mechanistic data proving that, you know, if early in life you have stimulation, you have a responsive caregiving, you reduce violence, that kids are going to do better in school, stay in school, you know, receive higher levels of education. Then there's a lot of data about what higher levels of education mean. So they already think in that way. Policymakers are already thinking in that way. And if you're talking to the World Bank or USAID or UNDP development actors, this is the lingo they speak. A lot of interventions don't have return on investment or cost data. So just as a field, getting better at communicating, not just here's our effect size, but here's, you know, within the system, what it would cost and what it would then cost to scale with the quality improvement elements.
Yeah. Any other questions? I have tons of questions, so I can keep going. You know, Theresa, you know, your work has really been focused on resiliency and modifiable factors that are protective. And, you know, you've got 20 years of experience just looking at communities that have been exposed to trauma and adversity. Can you tell us a little bit about what you think are, like, say, the top 3 modifiable risk factors that we as public health professionals should really be focused on when we're thinking about strengthening families, and especially within refugee communities?
Oh, refugee communities. Well, I don't have longitudinal data on refugee communities, so that was a twist.
Okay.
War-affected
communities that have been exposed to a lot of trauma.
Right. War-affected communities exposed to trauma, we do have very strong longitudinal data. And, you know, we recently published a 15-year follow-up of the former child soldiers in our sample in Sierra Leone, looking at trajectories that were sort of, and one thing to note is the general trend is improvement. The general trend is not devastating underdevelopment and loss of human capital. That's like 10% of our sample. And those are the kids who experience high degrees of community rejection, social stigma, and poor support from their families. They didn't have that guidance. They didn't have the social support. And we see those kids continue to have very high rates of mental health problems, involvement with the police, suicidal ideation and attempts, but we do see for individuals who experience attachment, so a loving, committed attachment figure, and it doesn't have to be mother and father, it can be alternative family and attachment configurations. That's fundamental. That goes all the way back to Yuri Bronfenbrenner, having that one person who's committed to the child, that attachment figure. We also see the community relationship and community acceptance dynamics of the degree to which there's integration, and that gets back to the collectivity in so many cultures, these issues of community relationships and stigma. It's sort of like the reverse. Community acceptance is very protective, and stigma is very toxic in our study. And then we do see continued, again, getting back to that economic data, just a chance to advance oneself through staying in school is highly protective for kids in our sample.
Mm-hmm. Thank you. We have a question in the chat. How do you respond to the idea that your work is imposing parenting styles on groups that may already have its own ways to raise children?
Yeah, no, this is a big issue, and especially the gender dynamics, right? And a lot of what the Play Collaborative is trying to do is, through local partnerships, think about the home environment in ways that maybe violence has been normative, and maybe people have been using harsh punishment, and maybe there's been a tremendous amount of intimate partner violence. But there are other ways, even in Rwanda, to raise children without relying on violence towards children or violence towards women. And so there's almost this element of positive deviance or other ways that already exist within Rwanda, and champions who can talk about that. And I think, yes, we can do home visiting at the individual level, but this is when the Play Collaborative multi-level style really comes into play, because you do need those males, the elders, talking about ways in which violence isn't productive for households, and role models who can talk about other ways of raising their families and what it's meant for them. So these are definitely issues, and we find resistance sometimes even in our home visitors. We have to really, as a group, talk about, it may be the case that that was traditionally how things were done, but are there other ways that things are also done in Rwanda, and what are those examples, and how can we begin to open up opportunities for more of the nonviolent ways of parenting and the more gender equitable approaches to also emerge, because they also do exist. We're not introducing some outside concept. And I think, you can only get there if you have these community advisory boards and have these opportunities to have discussions about different manifestations of parent-child and intimate partner ways of being.
Mm-hmm. Mm-hmm. Yeah. Great. We also have a question from Carolina Vega. Go ahead, Carolina.
Hi, first of all, thank you so much for such a wonderful first having us here. It's a really good opportunity, and thank you, Theresa. It's such a wonderful, it's really great to hear you. So I had a lot of questions, but I'm going to ask just a few. One of them will be, how do you work first with governments? Well, I live in Ecuador, and we're doing a research here as well with Panama, and when we're talking about or training people from the government, usually they have a lot of rotation. So I don't know if you ever had like a strategy. So this will continue, because I see that you went along a year and you still see an impact. So maybe that means that in the government as well, there is a strategy that you get to, for the new ones and the people that comes inside the government, again, they know about this and they are able to continue with this. That would be one.
It's such an important issue in working in partnerships with governments. And we've learned never to put all our eggs in the basket of just the minister. There are always technical people, permanent secretaries, people in the appropriate ministries who don't turn over when there's political turnover. And so you can't just focus on the highest level person. You also have to do the outreach and the sensitization to people in the technical roles who are going to persist even when there's political change. And it's always a setback when we get a super invested, charismatic leader in the government who's our major partner. That has absolutely happened to us. And then that person is replaced or the government changes and you've got a new administration. Now, Kagame's been in office in Rwanda a very long time. In Sierra Leone, we've definitely started with one government administration, done all of that sensitization, bringing you to the State House to talk to the ministers, getting them very excited and invested, and then having elections and everything turns over. So anytime we go to government meetings, we're really intentional to try to nurture, yes, the top people, but also the more technical people who will stick around. And it's also, again, it's just about like taking it very seriously and putting real effort into it. You can't do all the research and then go to the government. Rwanda is very clear about, you are with us for every step of the way or we're not interested. And so it really becomes something that we have to put constant energy and effort towards, but the payoff is huge.
Thank you so much. Yes, I totally understand that. And that will bring me just to the second question. It's about how did you manage the flexibility while you were in the implementation phase between sites? For example, do you see this model could be replicated in Latin America? It will be wonderful. We definitely would need that.
Yeah, actually, I have a colleague, Maria Piñeros, who is adapting this for Colombia. So we actually now, Colombia is affected by violence. We have the same issues of intergenerational violence and poverty. So there's actually an effort now to adapt this to Latin America because the father engagement piece is so rare. There are other great ECD interventions going on in Latin America, but maybe less focused on ECD and violence prevention and that father and male engagement piece. So actually, we've been able to see some promising possibility. And I think there is a lot of flexibility as long as you keep those core themes and the core evidence-based practice. If we're systematic in how we think about adapting it to new cultures and don't just assume everything that works in Rwanda is going to work in Latin America, there are actually frameworks and implementation science that take you through the sequential stages from using the early qualitative work to review of the intervention materials, to working with community advisory boards, to getting a beta version, to running a theater test, to doing, the early pilots on Do No Harm. There's some nice models out there. One is the Adapt It framework, Adapt IT framework, which we like a lot. We've been using a lot more systematically, and that's exactly what Maria and Alicia de Rogers are using and adapting this to Colombia.
Great, thank you so much. Well, count me in when you're around Colombia.
Yeah, reach out. I'm happy to put you in touch with them because hopefully we'll have a Spanish-speaking version, at least for Colombia, and then who knows what we could do in other parts of the world.
Great, thank you.
Thank you. We have a question from Encounter 31. Do you want to go ahead and ask your question?
Hello, I would like to ask Ms. Betancourt, from her work going to Rwanda, has she observed violence, or was that reported to her? Would she have an example of what she observed as violence in the home over there?
Yeah, I mean, we've been working in Rwanda a very long time in partnership with Rwandans. So when I spend time in Rwanda, I'm really working with Dr. Vincent Sezibera, who is the local PI. He's the director of the Center for Mental Health at the University of Rwanda. He's a psychologist by training, and historically had done really important work on intergenerational trauma, given the history of genocide in the country. There are certainly instances in families where, given the trauma of the genocide, given loss, a lot of the parents today lost caregivers, lost extended family, were affected by that conflict themselves personally. So there are situations where people are also engaging in violent behaviors in the household, including sometimes in our early pilots, some of the regions we worked in, there were fathers who'd been genocidaires who'd come back from prison and were drinking heavily, and then were being violent with their partners sometimes, really frightening situations where it wasn't safe for the mother and the children to stay in the home. And in those situations, what we would do is work with local leaders. And it's almost in Rwanda, it's a system that's something we don't even have here in the United States. You know, we're very police and sort of judicial system focused when it comes to prevention of violence and responding to violence in households. But in Rwanda, yes, there are the, you know, sort of police structures, but there are community elders and leaders. And so when there's violence in a household, like I said, a lot of these families are known, you know, they've been living in the household for, or living in the community. And so community elders know and can be involved in problem solving and talking to that dad about his drinking, finding a way for the mom to be safe and making decisions about the safety for her to return, or if the community needs to find another living situation, or if a crime has been committed and the person has to be held accountable. So, and everywhere in the world there's violence. Rwanda is no different than anywhere else in so many ways. But it does have some really important ways in which community responses to violence are even stronger than what we see here in the US.
Mhm.
So those partners, alcoholic who became abusive, do you do some kind of work with them directly?
Yeah, a lot of them have a trauma history, and there's a much more effort now in Rwanda to develop access to trauma-based mental health counseling services, especially at community health centers. Some work around substance abuse treatment, less so access to evidence-based substance abuse treatment, but we are able to make referrals to local psychologists, to social workers, depending on what the family's needs are. And that's what's nice about home visiting, because you can have that more individualized approach to the referrals that are needed to getting people into care when sometimes they've been out of care.
Mhm.
Thank you, Ms. Betancourt. Great work.
Yeah, thank you.
Yeah. Theresa, I was wondering if you can talk a little bit more about the learning collaborative work that you've done, and especially around you know, the multi-state collaborative that you want to do with the youth strengthening program or the youth readiness program, because I think that there's probably potential room for collaboration there. And you know, I'd love to hear more about, you know, how you're approaching that and where you're at with that.
Yeah, I'd say our best, I mean, the collaborative team approach is what we're using in the Play Collaborative, right? So that's the one I presented today, is probably our best version of a learning collaborative, and that's involved 3 districts in Rwanda. And you can see, you know, that there are routine meetings, the kind of themes that come up in the qualitative data, the use of PDSA cycles.
Mm-hmm.
The other one I've had experience doing is the one in Sierra Leone that I mentioned, that was much more challenging because of communications being really off the grid. And so, you know, what we had to innovate like crazy just to deal with the lack of phone network and no access to Wi-Fi. So we had to place our expert out there regionally. They would host the local sessions, but then how are you going to have cross-site learning? So if you've problem solved with all the facilitators of the youth readiness intervention, but how is, you know, Kai Lown district going to learn from Kono district when no one can easily get together because it's, you know, bad roads and no Wi-Fi, no phone network. So the expert who was based out regionally had to then use their notes, come back into a big capital city where they could have access, and then we would facilitate just a very simple cell phone call between all of the district leads on some of the cross-site themes. But even with that, we were able to identify some quality issues that if they had not been nipped in the bud would have been a huge problem. So with the youth readiness intervention, which is the cognitive behavioral therapy-based intervention that we integrated into schools in Sierra Leone and then into youth employment programs. It's meant to be done, there's a women's group, you know, and we've tested it everywhere from 15 to 30 now. It's meant to be facilitated by, you know, the women's group is meant to be facilitated by young women and female facilitators, in the men's group by young men, male facilitators. But one of the districts trying to get, you know, big numbers all at once was wanting to combine them. That would not be considered quality implementation of the youth readiness intervention. And so we realized they were having a time pressure. So let's problem solve with them. It would not be adhering to the evidence-based practice to blend the males and females. But if you're having a time pressure, let's look at other things that could be possible. So in those cases, we actually found out that a lot of the youth were idle in between sessions. They were in these entrepreneurship training programs, but they were only having their youth readiness group once a week. and there weren't a lot of jobs, a lot of employment out in that area. So the youth were more than happy to have 2 or 3 group meetings a week. And that absolutely fit their context and was a good problem solving effort rather than what they had thought about doing, which is combining the groups. So that's just one example of like using a PDSA cycle, even offline, in a way that was productive and meant that another district didn't do a low quality implementation because of a barrier. So that's the youth readiness intervention, learning collaborative or collaborative team approach, because it was regional, it wasn't really an interagency learning collaborative. Then you've got the play collaborative I presented on here in Rwanda. With the refugee program, right now, just in the 2 studies we've done, it's just been 2 agencies. We've been working with Jewish Family Services that works in Springfield, Massachusetts, that serves the Bhutanese refugees. And then we're working with a mutual assistance organization that's run by refugees called the Maine Immigrant and Refugee Services, or MEARS. And so those are 2 very different types of agencies. You know, Jewish Family Services is linked to HIAS and all the resources of that international network. MEARS is run locally, and they get all their own small grants, and they have partnerships with, you know, the state of Maine and Lewiston, Maine government. But in those 2 models, we were testing, well, how does it go when the home visitor, the refugee peer, is hired by the program hourly to do the intervention, compared to when they're an embedded community health worker, maybe doing other things already, like TB screening, which, you know, the state of Massachusetts already pays for. So Jewish Family Services already had these peers linked in, doing other forms of community health work, and also working in the intensive home visiting program for kids who carry a mental health diagnosis. If a child already has a treatment plan and an Access Fund diagnosis, it can be billable to do family home visiting. And so for us, that model's been a lot more efficient, and is something now that is billable in Maine if a child has a mental health diagnosis. I think the real innovation that for the Afghans that would remove a barrier would be, can we do this knowing that these families are already high risk, that Afghan refugees are coming with tremendous trauma, acute trauma that face the kids and face the caregivers. So do we need to go through the bottleneck of having these in-depth mental health assessments by a licensed professional to identify and only serve those with a diagnosis? Or could we, in a prevention model, finance family-based prevention done by peers that doesn't require a diagnosis to do that, because it's prevention? And the risk factors are, you know, already quite profound within this population. Plus, they're coming from being in military bases, separated, you know, from all their loved ones back in Afghanistan, all the strain of that. But financing that takes some creative problem solving. So what we're proposing to do is work with states that are resettling Afghans that have high political will to be creative on the financing. And so there are several mechanisms. There's the Refugee Health Promotion Program that's been around a long time. There's a new bolus of money specific to the Afghan resettlement. And there's actually a mental health initiative for the new Afghan resettling population, which is really great to see coming from, you know, the US government and Office of Resettlement, really innovative leadership there. So, you know, to do a learning collaborative, we have to work in states where they want to do this. And so it's got to be a coalition of the willing. So we've now presented to the Association of Refugee Health Coordinators for all the states. And we're inviting interest from those states where they'd be willing to work out the financing to cover this in some of the available resources. And we would provide the technical assistance. And the technical assistance would not be me, would be our refugee experts, because we've got experts in doing home visiting who are refugees. Based at our site in Maine and based at our site in Springfield, Massachusetts. And the best of that group could become our seed team. And so the idea is to do the training from the refugee experts to the new refugee populations. And they, again, that same adapt model that I was talking about with the formative qualitative work, with review by people who know the language and the culture, with review by community advisory boards, with a pilot sort of theater test, with refinement. That's the process we're looking to kick off now, and are hoping to start to go out to some of the military bases to do some of that basic community-based participatory research with the free listing and the key informant interviews to get at some of the language around protective resources and non-stigmatizing ways to talk about mental health. So we're kicking off the process, but who knows what states it will be, because that's really a matter of political will.
Yeah. Wow. Well, that's just so exciting and so incredible to be, be able to try to do this across states. I think this will be amazing.
It would be. Let's see. Have you guys done a cross-state initiative? Do you have experiences on doing that?
Not across state, but I think there's certainly examples of that. As you know, through the National Trauma Network.
Yeah, Child Traumatic Stress Network. Yeah.
And then
we're talking to them, so we're gonna get all the lessons learned that we can. And they actually have
it would be the best. And then we've been doing a learning collaborative through the HEARD project. But we're not really doing the PDSA cycle, so it's not so much quality improvement, it's more about learning community. So I think with the cross states, you're going to have so many different policy issues and financing issues, and so that I'm sure it's going to be a lot more complicated. Given the different systems that need to be engaged.
Yeah, I think so too.
Do we have any last questions? We have room for one more question. Oh, anybody else? Okay. I guess that's it. Well, thank you, Theresa, for joining us today and sharing your knowledge, your insights, all of the wonderful work that you've been doing. It's just so inspiring to see such transformation in the field, and especially in an area that I think is so understudied and so difficult to make an impact on. And so to see you making an impact in child, diversity, preventing violence, working with the hardest to reach communities, it's really inspiring and incredible. Thank you so much.
Good partnerships and amazing people like you all. So I've really appreciated meeting all the faculty and students here at CUNY. You're doing amazing work, and to get that expertise in implementation science is so needed. So hats off to all of you, and it's been my honor.
Thank you for being here. We've got a couple of more questions. Paulo, you have your hand up, and I think we had a hand up for Carolina as well.
Yes, hello, me again. I just want last question. I just want to know, Theresa, what is your perspective, or how do you feel that it is coming in the founding part for programs like this? How do you find like the upcoming in the next year scenario for founding research and programs like this?
So sorry, just to make sure I'm answering your question correctly, how do we find like what's up and coming and the funding, or say more?
Yes, no, just your perspective. How do you feel that right now? Mainly, I'm thinking about the COVID conditions that right now there is a lot of going to that side of the foundings and so on. So I was wondering, what is your feeling and thoughts about next year and the founding programs like this one that you're presenting, or similar ones?
For funding.
Mm-hmm.
Yeah, I mean, I do think that big development actors like USAID, it's great that you all have the work you're doing on HEARD, which is explicit, to have a focus on implementation science. I think the World Bank and others like that are really interested in moving beyond randomized control trials. It's a necessary first step. You got to show that the thing works before you try to scale it. But the science of scaling and sustaining quality, I think, is really the wave of the future. And I think people like Vikram Patel and others who really brought this focus on task sharing is so exciting. We can show that you can do it effectively, but how can you then sustain results if you're beginning to think about system strengthening and task sharing and how you link up those systems? So there's just so much space within implementation science to take these models that we're using that really grew out of like quality improvement and healthcare system strengthening and even management principles, and bring them to very low resource settings globally. I think there's a lot of interest from funders and more RFAs around these lines, and a lot of people who don't know the science in a rigorous way. So those of you who are getting that kind of training, it can really distinguish you.
Great. Thank you for that feedback.
Thank you. Thank you so much, Theresa, for being here and just, everything that you do.
Thanks to all of you.
Everybody, Theresa's hiring, her team is expanding. And so if anybody's interested in any of the positions, please feel free to reach out to Theresa or reach out to myself and I can forward you information about the positions available.
Yeah, we'd love that. Thank you.
Thank you.
All right. Thanks, everyone. Great to meet you all. Keep up the amazing work.
Thank you. Bye.
Bye for now.